The teaching of skills within this video in no way implies that the viewer will be able to perform the skills. The skills viewed may only be performed when authorized by a certifying or licensing agency. Any devices used in this video are for demonstration purposes only. Other brands may be used as per local preference.
This video will demonstrate how to implement spinal motion restriction for pediatric patients. Conventional spinal immobilization using flat, rigid surfaces causes several harms when it is not necessary. These include pain and anxiety, restriction of breathing, and development of pressure sores, which begin in less than 1 hour. Therefore, spinal protection or spinal motion restriction is the current preferred practice. Spinal motion restriction has 2 separate components: a spine board or other lifting device used to move a patient who cannot ambulate, and a cervical collar used to support a potentially injured or unstable cervical spine and to remind the patient not to excessively move his or her head or neck. For a child with moderate or severe mechanism of blunt trauma, assess the need for cervical collar. For a child who is unconscious, has altered mental status, is complaining of neck pain, has experienced a high-energy mechanism of injury, has neurologic deficits or weakness, or a diving accident, proceed with application of a cervical collar. For children with moderate or low mechanisms of injury, if the child is ambulatory and fully awake with normal mental status, is moving the neck freely and has no neck pain, has no neurologic deficits, and has no significant trauma to the head or torso, a cervical collar may be deferred. Align the head and neck in a neutral position. Provider 1 holds manual traction with his or her palms against the side of the head and thumbs stabilized against the patient's clavicles. Provider 2 will apply a appropriately sized rigid cervical collar. If no appropriate size collar is available, Provider 1 should continue manual stabilization as the patient is placed on a spine board or stretcher. If no cervical collar is available, or if the patient is not able to ambulate, transfer the patient as a unit to a spine board or alternate stabilization device. Some small children can be lifted up with hands under the buttocks and shoulders directly to a stretcher, or to allow the stabilization device to slide underneath. The provider holding cervical stabilization will lead the count to synchronize the log roll for adults and large children. The log roll is a good opportunity to examine the patient's back and buttocks for signs of injury. Small children may require a shoulder roll to elevate the shoulders and accommodate a large occiput. Without the shoulder roll, the chin can be pushed down toward the chest and the neck placed in unnatural flexion. To check for the spine in a natural position, look for the shoulders to be in line with the ears and the face looking straight up. For patients who require conventional full spinal immobilization, such as unconscious children with multi-system trauma, apply straps to hold them in place with the body first, legs second, and tape across the forehead last. If you are using props for head stabilization, place blocks or towel rolls on either side of the head prior to the application of the tape across the forehead. If the patient has a cervical collar applied and is able to ambulate, allow him or her to assist with getting to the stretcher and lying flat in a position of comfort.